Thanks for the invitation. It's a true pleasure to be here to talk about our experience in telemetry and bariatric surgery. So that's my disclosure, is have a grant and also do some consulting for them, but not relevant to this talk. So we already know that telemetry can provide remote, real-time guidance and technical assistance to surgeons across the globe, and can actually really make a difference. As far as also, there is also no difference in the knowledge acquisition between mentoring versus telemetry. And also, we can achieve like a potential to make democratization of knowledge across the globe. So I mentioned again the Project 6. One thing that was very important that was stressed through like the 2 days we spent in Los Angeles was that to be a mentor and a mentee within the framework established by the Project 6, you have to have an established relationship. The mentee should be capable to perform the procedure itself in case the networks get disconnected or something like that. And should follow the educational framework where the mentor and the mentee going to go through a didactics, then going to go to perhaps a hands-on course, and then finally going to be the mentoring portion. So there's different ways to do, different platforms to do telementoring nowadays, like a lot of hardware-based ones and a lot of software-based ones. One of the most famous ones was the Google Glass. We're using Google Hangouts, but it's absolutely like a non-HIPAA compliance. We personally had experience with using the Google Glass initially for surgical telemetry for both open and laparoscopic surgery, but it was absolutely suboptimal because of the type of technology we're dealing with. But then we were fortunate enough that we participated on the SAGES sleeve gastrectomy telemetry quality improve initiative, and also we were able to perform surgical telemetry during the SAGES, which was in Boston. We're going to talk about those two experiences. So, and why bariatric? Bariatrics is a very rapidly evolving field. Every few years we got a new procedure, and people got very excited about adopting them. And a lot of the times they are not trained. So they come to a meeting such as SAGES, they see an expert talking about, they perhaps go to a hands-on course, and then go back home, and then they try to apply that. So sleeve gastrectomy back then was perfect to be an example for this, because if you go back about 7 years ago, sleeve gastrectomy was on the single digits. Now is about close to 80% of all the bariatric procedures performed in the United States and the world as well. Of course, there is a learning curve that if the person doesn't know what she's doing right in the beginning, going to make longer cases, and it can cause high morbidity. And we know that the mentoring can actually expedite this process and make it safer, right? So go back to the foundation of advancement of medical education. They actually gave a grant to SAGES to do that project. They have established that to properly introduce a new procedure, a new technology in the field, you should have the structure, the didactics, then hands-on lab or simulation, and then on-site surgical mentoring. And that's what is missing a lot of the times that a new technology or new procedure is being introduced. So, in why mentoring? So mentoring, like real-time support and guidance, reduce error and improve efficiency, and of course patient safety, and of course improve outcomes. But at the same time, there is a disadvantage of being on site because it's time consuming, loss of productivity, schedule conflicts, travel cost. Imagine that you have to abandon your practice for 2 days to travel across the country to proctor one case, and then that case may get canceled. All those problems make people not to be that eager to be mentors. So within this study, which was led by Dr. Ninwen, what's called the sleeve gastrectomy telementoring, a SAGES multi-institutional quality improvement initiative, was University of California, Irvine, Montefiore, Mass General, McMaster, Loma Linda, and 2 private surgeons overseas. And the goal was not to see if there is improved patient's outcome, because the number, of course, are very small, but was to evaluate the feasibility, the efficacy, and the satisfaction of the surgical telementoring experience for sleeve gastrectomy. So adopting this educational process by FAME, what we did is the mentee had to review online learning didactics, or either from SAGES or SMBS. Second step was, instead of being physically in the operating room observing surgery from the prospective mentor, you have to do a tele-observation of those procedures. And then finally, we replaced the on-site mentoring for telementoring. And what is the prerequisites? like Dr. Page is talking about, what a mentee needs and the mentor have to have a pre-established relationship. The mentee had to have a moderate to extensive experience in the procedure in case there was a disconnection. The mentor had to have at least, which established 75 prior laparoscopic sleeve gastrectomies, be currently teaching the procedure in a residency or in a fellowship accredited institution, and be participating in the quality improvement metrics. Those are the number of cases performed in those institutions. And 2 of them were overseas, one in Guatemala and one in Argentina. In the United States, what we have to do, we have to pair the mentor and the mentee per states because of the licensures. So for the privilege and the malpractice coverage, so none of the institutions who actually end up participating through the entire process, they actually require privilegings from the mentor into the mentee institutions. Also, the mentors, they check with their own insurance companies to see if they would need some special coverage, but they said no for like those eventual cases, and therefore additional malpractice insurance was not necessary. Logistics. That was probably the most challenging part of the entire project, which took years to be completed, was because of scheduling conflicts, even though they were being done at distance, but a mentor has to be available when the mentee needs it. Sometimes the mentor is doing their own clinic or operations. Shipping the Visitor One, we're going to talk about, that's our platform. And that actually was quite challenging sometimes because or either your hospital is not ready to receive it, or the company cannot ship it, or the other institution haven't finished the trial yet. Set up the telemetry equipment. So you have to have a dedicated OR, of dedicated firewall. So there is a lot of hurdles that have to jump through it. Many meetings you have to go through it. It took me about 2 weeks of going back-to-back meetings with all the parties involved to actually allow us to do that. And questions always arise: why are you even doing this, right? And of course, getting the patient consent. That was very important because you're going to tell the patient there's going to be another surgeon involved that you don't know, but the surgeon is going to be at distance. And I'm ultimately going to be the person responsible to doing those procedures, but this is part of a trial. But none of the patients actually refused that. So the platform we used was the Visitor One by Storz, which is it's got a tall, large robot like this. It's a nice monitor. I'm going to be showing the image in a minute. You can either connect through Wi-Fi or cable, and you connect the unit through apps installed with laptops or portable devices. So it's a two-way, both video and audio communication, real-time, with high fidelity between the mentor and the mentee. And the system transfers both the image from the operating room, but also the image from a S video. Could be also an endoscope or the laparoscope. And finally, there is some educational tools for telestration, capturing imaging, and laser pointing. So this is from the vendor. You can see those 2 cameras. You can use the laser to show where incisions should be placed or where your port sites should be, or to point out a structure. You can also, like I say, freeze an image and then telestrate and put some annotations and give some suggestion for your mentee. So image from the iPad, watching the procedure, mentoring the mentee through an iPad, through a laptop, and the image inside the room, right? This is like a bird's eye view from a black diamond looking into the interaction. You can look at actually the Visitor One is at 3 o'clock, which can look at the port sites, can look at the field. Do I have audio? I was going to play this again, but we can see, I have laser here, right? The laser's okay. But you can see, is it? Right here, got it. So that's the Visitor One right here at 3 o'clock. That's the surgeon, the assistant next to each other. And you can see like minor things such as, this is like one of the most common mistakes made by novice surgeons in sleeve gastrectomy is stapling too close to the incisor angularis. Like literally the mentor just say, you're gonna pull this a little bit more, and then a malpractice, a issue, a complication is already avoided. So what are the results, the perception for the mentees? So the tele-observation of those initial sessions and the telementoring sessions was 93% of exceeded expectations. Also 93% exceeded expectations for the quality of the telecommunication, 87% for the latency of the telecommunication, and the visual clarity and the sound clarity was 67%, and there was no unexpected occurrences. This is the view from the mentor, looking at a laptop. Some of the mentors actually they chose to use mobile devices, so you don't have this option to do like dual imaging. So the results for the mentors were actually were 7 mentors, 15 mentees, 7 mentors. The quality of the telecommunication and the latency was 54% exceeded expectations. The other ones met the expectations. And the visual clarity and the sound was 41% and 59%. It was interesting that for the trainees' standpoint, the quality was better overall. And for the mentors was less optimal. But overall, when asking them about the whole experience, was pretty close from 1 to 5, 4.8 for the mentees and 4.7 for the mentors, and no unexpected occurrences. So of course, we have limitations on any trials. For this, we have a lot of schedule conflicts between the mentor and the mentee, patient's delay. The telemetry equipment sometimes not always available. Technology limitations, equipment malfunctions like expectation of the S video wasn't working, issues with the institutional firewalls, transmission interruptions, among others. But they were occurring in only 3 cases. In legal, there was one instance that the mentee's hospital did not allow the mentor to get privileges to actually mentor the institution. But overall, there were no reported intraoperative or postoperative complications related to this. So talk about the second experience we had. It was this we call like the SAGES Boston Telemetry experience, which was a demonstration of the safety and feasibility of a live telemetry in front of our audience. And we used the framework from the Project 6. So we literally followed every single one of those steps. It was on a white paper to make this happen, from the regulatory, for the education, for the legal, for everything. And the result was quite interesting because I was involved on this. And first, our hospital didn't want to participate on this at all because it said, what if something goes wrong? What's going to be the perception of the Master General Hospital if this goes wrong, right? But after a lot of meetings, explaining to them and showing the feasibility, and after going through this leave trial, they were much more open to it. So then they dedicated a team to make it happen. So I have like 3 engineers, one of the top ORs in the hospital. We have a dedicated internet connection. And the same thing was happening at the convention center, where we're like being 100% sure that everything is going to go as smooth as possible. So we took the advantage that SAGES was in Boston, and we were already involved in telementoring with SAGES. So we proposed to do 2 cases, one on Thursday, one on Friday, where the attendees from the exhibitor hall were going to be watching from like a mini theater, the procedure which was happening in the MGH. The mentor was at the exhibitor hall with the audience, but to protect the mentor from the audience questions and be disrupted, just like engage with the mentor-mentee relationship, we put a commentator which was explaining all the nuances of the telemetry. And again, those 2 surgeons, what's me and Denise G, we had a pre-established relationship. We're both licensed in Massachusetts, had privilege at the MGH, have done extensive amount of sleeve gastrectomies. But the difference was, I do my case in French position. She does her cases in a regular supine position. She starts in one different way. I started a different other way. So we were like open to learn the other's technique. So that was the visitor 1, which I already showed. That was our network parameters were pretty good. That was where we set the booth for what's called the spotlight on telementoring. That was the image that the public was looking at before starting the procedure. That was the OR setup. On the beginning, we had visitor 1 on the back. That was like being protected, line that there was nobody could actually see what's happening there, whereas the patient gets completely draped. It was interesting that the second case, we had a anesthesia emergency because they couldn't intubate the patient, totally unrelated to this. That actually delayed about 30 minutes the second case, but everything went absolutely fine. And you can see the visitor one. So the niece preferred to have the visitor one for her cases on the back, which you can still see the field, and you can still see the images, including where it was recommended the port side placement, even being like in the back. And that was the mentor's view. And that was my preference with the one at 3 o'clock. So the network quality was pretty good. We only lost the data like in less than 3%. Although, like I said, it was a dedicated line. We both felt very comfortable about doing the procedure, and the audience didn't interfere with the mentoring. So the limitations, of course, was a case study. We practiced in the same institution, and was a connection within the same city. So overall, all the lessons learned between all those telemetry in sleeve gastrectomy is that it is feasible, safe, and reproducible. It has become much more convenient, especially now that you can actually just log through your iPhone or your iPad as you're doing clinic, and then just go ahead and mentor somebody. Might be just a question, doesn't need to be mentoring the entire procedure. Telementoring sessions were able to be initiated by the mentor without difficulty with a good Wi-Fi connection. Also, we know that state licensure is an issue. Right now, we should limit ourselves to do between your own state, only if you have like a license in both states. Only except Delaware and Virginia, they accepted eventual, occasional telementorings, teleconsultations across the border. But we should definitely engage in advocacy for clear regulatory and legal guidance on how to make a national licensure or international. And also finally, like medical liability coverage was provided by the institutions of the mentors. However, this should be thought to be something that should be like initialized by the mentees institution to enable easier access for education. But again, so far now the mentee is ultimately discerning their own record and the one that's ultimately responsible for the patient. The costs were financed by SAGES, by some grants inside our own institution. And then in order for this to be widely adopted, the cost needs to go down. The equipment should become smaller and more portable. And we actually have a wide availability of like affordable high-speed connections. So in conclusion, surgical telemetry is feasible and has overall was high rated by both mentors and mentee on that study. Telemetry is an effective educational tool that can assist with conventional on-site and off-site surgical telemetry model. And the Project 6 framework can be effectively introduced and utilized in telemetry relationship. And telemetry can be successfully and safely performed with a live audience, large audience, allowing the educational value to be going beyond not just the mentor and the mentee, but people who experience that project. And I'll thank you for the invitation one more time to talk here today.